Any questions? Yes. Yes. No, that is just an epidemiologic. If you look at one strain, one single organism, that is the epidemiology that we'll see with these respiratory viruses. Well, why that happens is you can kind of understand it this way, is that you have a host, you have a pathogen, and you have the environment. So to cause a disease, you have to have a favorable combination of all three. So you have to have large amounts of pathogen inoculated into the right time and place, and a susceptible host. So there comes the host immunity, and the environmental factors that favor that transmission. So that's the causality of any disease, and that slide really pertains to more general for viral type diseases. That slide will come up again when we talk about some of the other pathogens. So we talked about parainfluenza viruses and specifically the types 1 through 4, and now I'm going into the RSV virus, which is a member of the pneumovirus subfamily. And this is a very important pediatric pathogen. I cannot emphasize or overemphasize this fact. But historically, RSV was discovered in the late 50s, and they found this from a related chimpanzee coryza virus. And somebody was not careful in the lab and got infected, and then they realized that this causes human disease as well. And we'll know a lot more about the RSV virus in the next 40 years. We've learned so much, including having some good immunoprophylaxis methods today. But this shows the formation of syncytium, which is the coalescence of cells to form one big glob of cell with many nuclei inside it, and this is the syncytium. This is more seen in tissue cultures rather than in actual patient specimens. Now, the classification, we talked about these the subfamily Pneumovirinae, and then the genus Pneumovirus, of which the chief member is the RSV. There are two subgroups, A and B, that have been described for RSV. Sharing some of the features of the other parainfluenza viruses are the size and the internal structure, but what is a little different in the RSV, I'm sorry to jump here, is this presence of the fusion protein with the absence of the HN protein. So this glycoproteins on the envelope are the G and F proteins, and the G protein does not have the HN activity, so it's not an HN protein. And the subgroups are defined on the basis of the G protein. The F protein is important for the fusion of the membrane, and actually that is the basis of the formation of syncytia. Again, it's a respiratory pathogen. It can enter through the eye mucosa because that is also a columnar respiratory epithelium. And then once it gets into the tract, it spreads kind of cell to cell from upper tract to lower tract. And so the first step is the attachment of the virus to the epithelial cell, which is via the G protein. And the F protein, like we said, helps in the formation of syncytia. This shows the budding of the virus from the membrane, which is kind of the latter step in the infection of a cell. Again, magnified view of the multinucleated cell here formed as a result of syncytial formation. This is really more of a cell culture description. So in terms of pathogenesis, when there is viral infection, this results in edema of the respiratory mucosal epithelium. And because of that edema, there's a lot of irritation, mucin secretion, and then there is death of the cells. And once they slough out, there is some debris created by that. Again, the mucin and the debris tend to clog the airways. And because you have narrow airways in children to start with, they also tend to be more collapsible because they're softer and less rigid. And so when you have that, along with the obstructed respiratory airway, you can imagine that it leads to an increase in work of breathing. There's also a lot of immune response to the infection, and that is in the form of lymphocytic infiltration. A lot of cytokines and lymphokines have been described in relation to the RSV infection. And these all lead to the clinical picture and severity of disease. So the disease is not just by the virus itself, it also is kind of compounded by the fact that there's a host immune response. And certain types of people tend to respond in a different way, and so the host response can lead for spectrum of severity of RSV disease. And some people who tend to be the atopic people or the allergic people, the ones who have eczema and asthma, and these people, if they have that genetic predisposition, RSV infection can be quite a terrible thing to have, especially at an early age, because it triggers the allergic response further, and those are the people that have been studied longitudinally to found to develop airway hyperreactivity for life. This is really a ubiquitous virus, and it's been described all over the world, and most children, again, have been infected in some form by the age of 4, which is a fairly important thing. To understand what else is going on with the burden of disease with RSV, it is really an important pathogen because a lot of hospitalizations, especially this affects young kids, airway problems, cannot breathe, it's quite severe, and these are some of the numbers in the U.S., and you can imagine worldwide there must be billions of cases that are related to RSV. Now, this seasonality is seen mainly in the temperate regions. Here is the picture from the CDC showing you data. This is a little old, but trying to show you the seasonal peak that occurs mainly in the winter months. Again, winter here, not so much during the summer, but there is some low-level baseline activity. It's not absent here, but it tends to peak in the winter months. And then this is the same time around which you're having influenza and other respiratory illnesses, so winter is really a bad time in terms of illness. This is, again, a shorter peak over here between the winter months, and the antigen detection is much more sensitive, as you can see. We'll talk about laboratory diagnosis, but the actual virus isolation is not as efficient in detecting the disease. These are more recent data, and going into 2005, but large peak during January and December. Short incubation period, like we talked about, the transmission directly through droplets and indirectly through fingers and fomites. And because of this, nosocomial spread is very common. And so in hospitals where we have RSV positive cases, knowing that this can be transmitted through the room surfaces, we tend to kind of keep them separated from the non-RSV positive ones. And so this is important in terms of hospital epidemiology. We talked about asymptomatic shedding, prolonged shedding, but it's important to remember, again, that the immune-compromised hosts tend to keep the virus longer and shed it for much longer. And infants, these are the people who are hit hardest by this disease, also show very high titers. And can you imagine that, a simple cold, what starts as a simple cold, a child sneezes, can have highly effective transmission to the caregivers involved. So it really is quite transmissible. Now, the spectrum of disease can be anywhere from a mild upper respiratory infection that then gets limited, or it can start as an upper respiratory infection, and then, as we talked about, the kind of subsequent involvement of the lower tract can lead to bronchiolitis and pneumonia. I can't tell you how many cases of RSV we see, and I've seen several of them, and it's just like every case has a little of everything, A bit of rhinitis, a lot of cough, a lot of these respiratory distress symptoms, and different severities as well. But apnea is an important thing to recognize because we see this a lot in very young infants who have RSV. They may not have a whole lot of this. They may just come in because of fever, a little cold, but not breathing. And these kids can really have true respiratory arrest, so it is quite important to recognize that. Here you see a child who is obviously working very hard to breathe. It's not your normal breathing. The chest is sucking in as the child inspires, and so that is not normal. And if you can notice these sternocleidomastoids, the accessory muscle use of the neck is also occurring. And so this is a child who's in respiratory distress, and the etiology of which could be quite varied, but RSV happens to be one of those. On an X-ray, you can see atelectasis, which is the collapsed airways, and this could be patchy, or it could be a whole lobe that has collapsed. And this, when it's a lobar atelectasis, you might have to differentiate it from a lobar pneumonia radiologically. But there's air trapping, and this leads to hyperinflation. And there's also these nonspecific features, which are streaking and infiltrates. So this X-ray, which does not look too much different from the previous X-ray that I showed you on parainfluenza 1 pneumonia, but if you see this area here, it looks a little more lucent than it should. And this is an area where there's actually hyperexpansion and air trapping. So this is a RSV bronchiolitis, nothing too typical radiologically about it. But the kids who are hit hardest with RSV are these group of children. These are the preterm infants. And now with modern technology, we are seeing a lot of premature births, and as early as 24 weeks. But the preterm infants, their first winter season is probably the hardest in their life because of RSV. And then we also recognize that children who survive that prematurity and end up having chronic lung disease are also hard hit. There's also a group of kids who have congenital cyanotic heart disease where the pulmonary vascular flow is increased. They're also at increased risk, as are the children who are actually in heart failure due to different causes. Immune-compromised patients, we told you earlier that they have prolonged virus shedding. They are hit harder by the virus, and they tend to be symptomatic for longer times as well. And people who have any dysfunction of neurologic or metabolic disorders that cause poor ventilation or that kind of, who have poor mobilization of secretions, they also tend to have severe disease. So it's important to recognize these subgroups because these are the groups that you want to target for any kind of preventative therapy. On a clinical level, we usually use the nasal or nasotracheal secretions. We have rapid diagnostic tests available, so within hours we can tell you, is this RSV or not? But it's important to remember, if you're trying to do antigen detection tests, it's not so important how you transport the specimen. But if you're trying to grow the virus, it is labile, and so you need to use a viral culture medium, and you need to transport it on ice. This is something that I end up telling people quite often because you will not grow the virus if you don't transport it right. And it's important at the lab end for them to also process it immediately and inoculate it into the appropriate cell culture lines. Now, viral isolation is pretty, it's not difficult to do if you can get the right specimen at the right time, and it grows fairly fast. Once you see the cytopathic effect, you can go into immunofluorescence and definitely define whether it's RSV and why. But the antigen detection, which is very readily available, is the ELISA or EIA, and this is used mostly in pretty much most hospital labs, and gives you a quick answer. But many times, if you don't get the right specimen, it may come back negative. And so sometimes we end up sending more than one specimen to make sure that if it's truly negative or positive or whatever. And as we mentioned, the antibody tests really don't help us clinically. They're more for epidemiologic purposes. Now, this is an immunofluorescence stain on cell culture. So you saw that the cell culture showed some cytopathic effect, and you wanted to specify whether this was RSV. You would do target the immunofluorescence stain, and if the cells light up, as these cells do, they have the antigen, and therefore this tells you that it is RSV. Now, when we have cases of RSV bronchiolitis, some of them are very mild, do not have the classical respiratory distress, and some of them are quite severe. And like I mentioned, the group of kids that are hardest hit can require hospitalization, intensive care, including mechanical ventilation. So for the mild cases, we just try to keep them comfortable, hydrated, give them the supplemental oxygen, and whatever. If they're having any bronchoconstriction, we can use bronchodilators, though some people think that this may not have a role. But the typical antiviral agents that were used in the early 80s, the ribavirin or Virazole, was really not shown to really clearly benefit these patients as much. And there were a lot of hassles with the administration because it had to be given by an aerosol. And if it was an intubated patient, it was difficult to administer. So at present, the recommendations do not recommend use of ribavirin except in very select, cases on a case-per-case basis. Prevention of spread, this makes a lot of sense because these are labile virus. They do spread through fomites and surfaces, so you need to disinfect the surfaces. But for hospitalized patients, if you know that they are RSV positive, you would keep them in an isolated room with contact precautions because you don't want it to spread through the fomites. So we do use this, and it's quite important in the peak of winter where you have a lot of RSV positive cases and many that are RSV negative, that you don't want to send them home RSV positive now because they acquired it in the hospital. So let's talk a bit about the immunization and strategies for prevention. Unfortunately, the active immunization for RSV was not a success. This is one of the cases of vaccine flop stories where the inactivated vaccine that was used actually was, because of some kind of host response, resulted in an enhanced disease in the vaccinees. That's the last thing you want to do with the vaccine, is to make them have more severe disease. So needless to say, that was stopped. And so at the present time, we do not have any kind of RSV vaccine. So what is being studied now is subunit vaccines that hopefully will not cause this enhanced disease. But as of today, we don't have any vaccines that are available for use. So the next strategy was to attack use passive immunization, where, okay, if you don't have the antibody, let's supply it to you. And this is very effective, and there are two products that we have in the market currently. The first one is called a pooled hyperimmune globulin, where they take volunteers with high RSV neutralizing antibody titers, pool their globulin, and prepare this product called Respigan. And this is given with monthly injections intramuscular, and it raises the titer of antibody, at least temporarily, in the recipients and kind of tides them by through the winter season. The second product is called Synagis, which is actually a synthesized monoclonal antibody to the F protein, so much more specific for RSV because they were able to target one of the proteins that is shared between the different RSV. And this product is called palivizumab, and the MAB stands for the monoclonal antibody. And the people that are targeted are the ones who are at risk for severe disease, like we talked about, the premature infants, the ones with chronic lung disease, congenital heart disease, etc. Because the cost of hospitalization for one kid with RSV, if they have severe RSV, involves 5 to 10 or more days of hospitalization. If they were very severe, they might require supplemental oxygen. And if they were really severe, they might require intensive care. When you add up those costs for thousands of kids, you realize that this is a very costly disease. And so when you look at the cost benefit, this is a costly product too. This is specially prepared. It has to be administered. It's not a cheap product. But if you look at the efficacy, if you prevent so many cases of disease, it makes it cost effective. And in these days, that's what we try to pay a lot of attention to. So we use a targeted strategy for immunoprophylaxis. We select the preterm infants. Before they go home, they're told that by October, you're going to get your monthly shot. You'll start your monthly shot of RSV, and that will tide them by the first winter. If they're extremely premature or they have some other congenital problems, they might get it for a second winter as well. But only targeted immunization, everybody does not get the immunoprophylaxis. The guidelines for use of Synagis or palivizumab were revised in 2003, and these are the current guidelines that we're using. And these target, again, the high-risk individuals, the infants, as well as some of the children with congenital heart disease, because with the previous studies with this product, they actually were not sure if this might be causing some problems and actually causing more complications, not RSV-related, but other complications like fluid volume-related in those subset of kids who have congenital heart disease. But the further data came up and showed that the monoclonal antibody product, which is not a large volume product, can be given safely to those kids. So they have also been included in these recent guidelines. And the efficacy of palivizumab is quite well established. It really cuts down the rate of RSV hospitalization more than half. So major, major benefit in terms of severe disease. And of course, when we talk about severe disease, we're talking about the kids who have apnea, who need oxygen, who need intensive care, mechanical ventilation, and that kind of stuff. So this is the success story in that sense of immunoprophylaxis. Any questions so far? Has anyone seen RSV disease? Yes? Can you tell me where you've seen it? You've seen it in the... Okay, can you tell us a little bit about it and just share what you saw clinically? It would be nice for others.
Yeah, she was hospitalized for 2 weeks. Had, a couple times a day they came in and had to stuff mucus up the lung.
How old was she? Yeah, there you go. Young. And the mucus is very thick and very viscid. There's a big problem with mobilization of those secretions. And those kids can't cough it up. They try. But it's so thick that it kind of sits there and blocks the airway, which is why they need to actually suck that stuff up. It is quite a terrible disease at that age. Can you tell us about the case you saw?
The nurse that was working on this baby, it was a premature.
Uh-huh.
Actually, about 4 or 5 cases on the rooms they had on. It was either RSV positive.
You had those signs. Yeah. That's called cohort nursing, which is you kind of separate those kids out. You try not to mix nurses, and you keep them well isolated so the other kids don't get it. Because who knows, you might have two doors down the hall, you could have a kid with leukemia. I mean, we don't keep our heme patients together, but you could have a kid who had a chronic neurological condition who would be at risk for acquiring that disease. And there was someone else who had seen a case of RSV? Can you tell? 11 months old. Did he need hospitalization? Okay, so he was maybe a milder case, was a little older. But you struggled with it for many nights, right? Yeah. But he didn't stay down at 89. He didn't need oxygen. Okay. Yeah. Steroids helped him? Yeah. Okay. Yeah. A lot of disease burden, very common, very, very common. And as adults, when you have RSV, you don't kind of get the lower respiratory tract, but you could have something that looks like a cold, and so that's RSV. Now, we have something newer to talk about. This is the human metapneumovirus, which is really gaining a lot of attention in publications. It is a relatively new pathogen on the scene, but it is a paramyxovirus, and the particles here is the typical the RNA, which is coiled up, and this is a disrupted particle actually here. The size is very similar, but what is different is this is like RSV. It's a member of the subfamily Pneumovirinae, and it's, I'm sorry for the typo there, it's a different genus here. And it was kind of discovered or rediscovered in the Netherlands back in 2001, and because they were able to grow the virus. It's not a virus that grows easily, but they managed to grow it. Once they grew it, boom, they had a PCR test for it. And then everybody started going back and looking at their banks of respiratory specimens, running the PCR and saying, hey, we have it too. And so a lot of literature is just booming with reports of how different places around the world are seeing this metapneumovirus. And it really causes the whole spectrum of respiratory illnesses from upper respiratory to lower. And interestingly, there are a lot of reports of co-infection with RSV. I find that very interesting that one would get 2 double hits here, And the labs that do the PCR, unfortunately, are not your commercial labs yet. So we don't actually know from a clinical standpoint how important this disease is. But I can tell you that there are many cases where you've suspected an RSV-like illness. It looks like RSV. You send the RSV antigen test once, it's negative. You send it twice, it's negative. And you say, my God, what is that? Maybe it's human metapneumovirus, and we have no way of actually picking it up to know for sure that's what it is. But it behaves like RSV, and it can occur with RSV. The other interesting thing about the metapneumovirus is it can cause upper respiratory infections, and half of these kids had otitis media. Now, whether it caused the otitis media or it was one of the pathogens that set up the stage for eustachian tube dysfunction and subsequent otitis media is not clear, but it is well associated with otitis media. So if you want a vaccine for otitis media, you could work on this one. So there's different ways of targeting the virus or the disease caused by it. And the lower respiratory tract symptoms are, again, bronchiolitis and pneumonia, and a lot of descriptions of these are coming out from various parts of the world here. I want to talk about adenovirus here. Are there any questions? And we will take a break after adenovirus for a few minutes. Any questions? Any comments? Has anyone heard of metapneumovirus? Okay. Well, it actually appeared in your 5th edition of Murray. It was not there in the 4th edition. There's a small blurb about it now. Okay. Adenovirus.